Hi guys, welcome to another edition of an OrthoHub webinar. My name is Ramon Tamasebi. I'm one of the OrthoHub team. And before I hand you over to this evening's host, who is Ali Noorani, I'm just going to do a tiny little bit of housekeeping and briefly introduce some of the content that we've got lined up for you in the near future. If you manage to visit our website or go onto our OrthoHub YouTube channel, there's a couple of really engaging and educational bits of content that we've released recently. We've started a series called Orthopedic Decision Making. It's video content that effectively takes the viewer through some of the rationale, decision-making, tips and tricks, pitfalls behind common surgical procedures. The first of our ODM series is about tibial plateau fractures, and in episode 2, Pete Bates and Alex Trompeter talk about Schatzker 2 fractures and how best to treat them. We've also got a new podcast that's been released, and that is with Lisa Hadfield-Law. Lisa has been instrumental with educating orthopedic surgeons via the Royal College of Surgeons and the British Orthopedic Association for some years. We're all interested in teaching and training and educating junior colleagues, and this is a really insightful piece about how we can improve what we do. Finally, after that, we have got a webinar lined up in early June, which is about use of total hip replacement for trauma. It's going to be chaired by Professor Mike Reed, and our guests are going to be Professor Matt Costa, Samantha Hook, and Anne Murty. It's going to be a combination of evidence-based discussion following the recent results of the health trial, as well as tips and tricks for fixing proximal femoral fractures and retaining the head, but also reasons why we should still consider THR as an option. So without further ado, I'm actually going to hand over to my old friend and colleague, Ali Noorani. In the chat just now, Ali and I were discussing the fact that we were medical students together some years ago at Stanmore doing an orthopedics BSc. We've known each other for a long time, and it's a great privilege to invite him as a host and a speaker at OrthoHub. He's a consultant shoulder surgeon from Barts with great experience and a well-known figure in UK shoulder surgery. So that's all from me. Ali, I'm going to hand over to you.
Thank you, Ramon, for that kind introduction. And again, thanks to you and OrthoHub for inviting me to give this, to chair this event. Proximal humerus fractures are rather difficult fractures, and today we're talking about everything to do with them. So today, as you can see, we have a real amazing faculty from USA, and we're going to talk about everything proximal humerus fractures. This, as you know, is a live webinar. We already have around 150 people participating in live. Please feel free to drop as many questions as you can, because we want to make this as interactive as possible. So without wasting any further time, I'm going to introduce you to Professor Eduardo Gonzalez Hernandez, who is a shoulder surgeon based in Miami. And his first talk is going to be talking about anatomy of the proximal humerus and how this influences fracture classification, as well as the rationale for plate design. Eduardo, you have the floor.
Thank you so very much. It is a pleasure to be here, and I have to thank Ali and Ramon for putting this together and doing this excellent effort in OrthoHub. We do need this type of venues for teaching, for learning, for advancing, and I really appreciate this opportunity. Michael Gardner and Joe Abut are incredible surgeons. It's a great honor to be here. So here is my presentation, and I'm going to have a good time with this because I'll be sharing a lot of concepts which you probably don't see in the typical American Academy or the our venues. this is an opportunity to talk freely, and it's great. Really, thinking outside the box is what needs to happen if we're going to make progress in this very difficult subject. So these are my disclosures. And I'll be talking a little bit about this concept of cross-screw fixation. And I hope to convince you that the effort needs to be made to better our devices, to better our understanding of these fractures, if we in fact are going to improve on our outcomes. And of course, there will be objections. I welcome the objections. We're going to have a good time today. So we need to start with a revisionary approach to fracture the proximal humerus. We need a better understanding about these fractures. We need to have a better understanding why locking plates actually fail so much. We need to have also more reliable implant design, and this will follow logically. Possibly, certainly expand our indications for internal fixation. We must not rely so heavily on the reverse shoulder replacement. For more success in our efforts, a systematic fracture reduction and fixation has to be done. And this is Michael is going to talk to you about in detail, and I'm really looking forward to that portion. He will present some challenging cases. But we need to depart from positioning the plate to the shaft. We need to reference our plate positioning to the center of the humeral head. That's departure from convention, and that's important. And then also including our methodology of X-ray techniques intraoperatively, that has to be improved as well. So I start by this diagram because it defines what our box is. Basically, our current understanding has a lot to do with our common language, referencing back to this 4-part diagram. But look, this is 1934, and this is 2004. It's the same concept. It's revisited, but it is the same concept. And most of us really know it as the near classification. But there are problems with it, very serious problems with it that have kind of misled us, have misled our understanding for so many years. This is a better diagram, and I will explain to you in detail why I think we need to change a little bit of the key diagram to this fracture classification. Number one, the lesser tuberosity is a bigger fracture fragment than portrayed in any other classification. The lesser tuberosity has the biceps tuberosity with it, and it has blood supply. And it is so important to consider it as a very key component in our fracture fixation. Must not be left unrepaired, or even suturing it is not sufficient. The greater tuberosity fracture fragment is usually a comminuted shell, one that typically or frequently will lose its fixation if you use screws. It must be repaired with sutures as a rotator cuff is repaired. And more importantly, in our fractures classifications, the calcar is not included, not mentioned. And it turns out that the medial calcar really is the key to these fractures. So we must revise how we think about this and how we draw these things. It's important. Now, when I think about fractures of the humerus, I think about the mechanism as well. For instance, you can have a mechanism which is an impaction type of a mechanism that leads you to this type of a pattern. And this one is a 4-part valgus impacted fracture. Now, we know from this article in 1991 by the folks in Bern that about 70% or the majority of these actually are reducible and do well even before locking plates were available. So this type of fracture, when we see it, should not be addressed with a reverse replacement. It's easy to reduce them, disimpact it, fill the void with bone graft, put your plate, suture your tuberosities, and be done. Expect a good outcome. Now, these other type of fractures, these valgus displacement, the mechanism of injury is a shear mechanism, a lot more damaging to the surrounding tissue. and leads to the failure of the calcar. So this is a very different injury, okay? So I would propose that we look at this with an additional uh, uh, a five-part fracture element. The five-part fracture is very different than a four-part fracture. So if we think about it in terms of the number of fracture components plus the mechanism, then we are going to be more capable on deciding which ones should be replaced and which ones should be fixed. So a four-part valgus impacted fracture is one that will do very well with the fixation. And a five-part fracture, including the calcar, lesser tuberosity and greater tuberosity, the head and the shaft, we're going to have a hard time fixing it uh, with conventional locking plates. And perhaps we should think about replacing them. Now, it is true that there will be patterns that we won't be able to recognize or fit into one of these two. But in general, it gives you an idea that there is a better way of understanding these fractures. Now, I'll make reference about this particular pattern of fracture. The 4.5 fracture, you see this uh, extension of the calcar into the humeral head. This type of fracture has a better prognosis because, as Hertel pointed out, you have better blood supply to it. And Brooks, 10 years before, also made that observation. I call that the Brooks-Hertel pattern fracture that is probably amenable to fixation. All right. So it's a classification that points out real fracture patterns. We may improve in our fixation of those. Now, let's look at why conventional plating fails. Well, our current box of understanding is this. We position a lateral plate and we expect that to hold the head in place. Now, you only have a 1 or 2 centimeters of cancellous bone allowing you the fixation. That's tenuous fixation. And of course, with micromotion, as the patient starts to rehabilitate and so on and so forth, there's no opportunity for healing, and there's erosion and the penetration, avascular necrosis, and all these problems. We know that articular penetration is very common, sometimes more than 40%. Fracture collapse is worse when valgus virus displacement. And avascular necrosis is a problem. These fractures do not have the opportunity to heal because of the micromotion, and there's no way that they can revascularize. So that is a real problem. But look, we had such good success with plate fixation in the distal radius. Well, the reason why is because the locking screws were really oriented ideally to counter the joint reaction forces. These screws are oriented tangentially to the joint. However, in the proximal humerus, the screws are oriented at right angles to the articular surface. And therefore, you are going to have erosion and joint penetration. It is simply not the same animal. It's a very different animal. And what happens if you suture the lesser tuberosity? What happens? The lesser tuberosity does not participate in supporting the humeral head, and then you get this basically the lesser tuberosity never does heal to the humeral head. So that's a problem. That's why we came up with this concept of a cross screw fixation to minimize micromotion, to augment soft bone fixation, and to support the humeral head with the lateral plate. So that was our notion, and we've been working on it for a while. And this is how you accomplish it. You do the plate fixation initially, and then if you need to use cross fixation, if you need it, then you have that available to you. You attach the cross screw guide, and through the guide, then you assemble the cross screws to the main screws in the plate. And so what you're able to accomplish is a veritable scaffold underneath the humeral head. And that can really counter the reaction forces and be an effective tool. And this is how we do it. You have the plate, you assemble the guide to the screw. The guide is assembled to the screw, not to the plate. And that's why it's so tremendously accurate. So this is the guide. We drilled through the guide, and just to show you, the accuracy is right on point every time. There may be a situation where you need to adjust the orientation of your cross screws, and it's very easily done. You just adjust the guide and shoot again. Um, the design of these multiple screws was done so that you could support the head, or in fact, you could fix the lesser tuberosity. And I will talk about that later. So the question is, does the addition of cross elements really help in prevent subsidence? Does it really work? And Ali, this is a study from your colleagues at Bart's, Damasio, Olivia Damasio, and his colleagues who have come up with this wonderful study. 15 patients, very well matched between the conventional plates and this cross screw fixation. What they were looking at, the subsidence, and it's by looking at the ratio between the length of the screw and the distance from the plate to the head, you can pre-op, immediately post-op, to the last follow-up, you can actually see if there was any subsidence or any complications. So these are the results. 15 patients in each group. In Philos, you have near 50% of subsidence. In Pantera, none. In varus collapse, you have one in Philos, in Pantera, none. Screw penetration, 30% in the Philos. And in terms of avascular necrosis, you have 3 patients in the Philos group with avascular necrosis, none in the Pantera group. So there is a clear evidence that the concept works. Now, we looked at it in a mechanical study, cross screw fixation in soft bone versus a conventional locking screw from Synthes, and this is what we found. A Synthes screw at the bottom of the curve, this is what it does to soft bone. This is the fixation you get compared to any other. The top line is our screw with 2 cross screw fixation. The performance is not 10% or 20% better. No, it's 500% better. The difference is remarkable. It's absolutely remarkable. The Synthes screw loses its fixation already within half of a millimeter of displacement. And within a millimeter of displacement, you're down to 50% of its fixation and losing more. So no wonder we have such poor fixation with these plates. Now, more importantly, if you look at the area under the curve for each of these graphs, that is the work necessary for screw removal. So if you look at this, what is the work necessary for removing the screw? 3 millimeters. For a Synthes screw is way down here, and for a screw with a cross screw is way up here. It's actually 30 times more work. So it's actually remarkable. All right. This is an article from our folks in Italy. 83 patients, 2-year follow-up, minimal IRB approval. It's a retrospective study, but the complication rate was only 9% compared to 40% that you typically see on the literature. Only 1 screw penetration in a patient where no cross screws were used. This article, this series, was basically the use of cross screws was discretionary. So not all patients got cross screws, and the surgeon could decide who would get them or not. But in any case, only 1 case of screw penetration. It's remarkable. 3 cases of avascular necrosis is also very low for this number of patients. So it is possible, and there is substantial evidence of this cross screw fixation. Now, with this particular device, you can use the plate as a conventional mode, or you can have the option of cross screw fixation. And so for the more unstable, more difficult patterns, you can actually resort to that particular feature. Now, a systematic approach. This is a slide that I'm going to skip because Michael really is going to talk about the details of the fixation. But I do want to point out that we must, once you do the preliminary you do your reduction in preliminary fixation, you have to reference the plate to the center of the humeral head and not to the greater tuberosity. And that's how you will succeed and get better reductions and less malpositioning of your plate. So that's important to get the perfect result. This is what you want to achieve. Uh, Now, very important, the Calcar screw has to fit in the lower portion of the humeral hemisphere to really be of substance. And then intraoperative imaging, well, usually I bring the C-arm from the opposite side of the bed, and this is easy to get an AP view. And this is an axillary view, a slight extension of the shoulder and rotating the C-arm in the opposite direction to get the perfect views. And it has to be easy. It has to be this easy. This is an AP view, and this is your axillary view. And you should be able to go back and forth without it being cumbersome, because the fracture itself is a challenge. X-ray imaging should not be a challenge. So very importantly, we must suture at will, and we have a lot of amplitude to be able to suture the cuff, the comminuted cuff. It's usually not possible to repair it with screws, so you have to have amplitude for repairing with suture. Now, here's the lesser tuberosity fixation. Lesser tuberosity is a large fragment. It has the biceps groove, and it is an important piece of bone with good blood supply. We must do better in terms of internal fixation. And we designed this guide not only to provide good support to the humeral head, but to provide an opportunity for fixation of the lesser tuberosity. This is how it appears on an axial view, and that important fracture fragment can be fixed and can be part of the rigid, stable fixation of our construct to really counter the displacement that you're going to see. And notice here, for instance, that what happens frequently when you get a vascular necrosis and you're using a standard locking plate is that the lesser tuberosity is alive, and there is a line of non-union between the lesser tuberosity and the humeral head. And that is because we don't have an effective way of repairing the lesser tuberosity. Sutures do not do the trick. So rigid fixation of the lesser tuberosity provides a better mechanical stability to the humeral head and an opportunity to revascularize the humeral head. In addition, if you have a rigid fixation, there's less pain postoperatively, and you can recover internal fixation better. Cross screw fixation, if you need to, is an option that I believe you should have, especially if you're a surgeon who fancies working on the proximal humerus. And the way to apply them is very easy. You slide extension and external rotation. The application of the guide no longer abuts the coracoid, and it's easy in this position to implant your cross screws. It's a very low profile manner of fixing the lesser tuberosity without violating the blood supply that travels along the biceps groove. So preservation of the blood supply, it's important. I have this case I'll talk to you that I like to share with you. 67-year-old gentleman with this fracture. And when you look at it, the head is completely dislocated, but within the fracture site itself, you have a greater tuberosity, lesser tuberosity shaft in the head, with a head that is completely looking 180 degrees in the opposite direction. 67-year-old, we proposed to him a fixation. He understood the concept, and this was 3 months after the surgery. This is 10 years after the fixation, with complete revascularization of the humeral head. He never displayed evidence of a vascular necrosis, but for 10 years, he's been able to work as a mechanic and doing heavy work. And in our older population, we see absolutely no subsidence through here. So it's really it's remarkable. Even in 97 years of age, who has this big calcar defect, very stable fixation. So we are excited about the option that you might have for cross screw fixation. And that's basically what I'd like to share with you. Thank you.
Thanks so much, Eduardo. I think I'm up next.
Yes, Mike, I'm just trying to see if I can start my video because it says I can't start my video because the host has stopped it. Carla, you may have to allow me to do that. Mike, I might introduce you while you are setting up your slides, and we'll open up some questions as well. So Professor Michael Gardner is a orthopedic trauma surgeon based at Stanford University. And today you're going to be talking about the surgical approaches and some real pearls on how to achieve reduction in difficult fractures. And before we start that, may I just ask a question to Eduardo and everybody on the panel about the risk of AVN, really? I mean, the risk of AVN often comes up all the time in our daily chat in the trauma room, right? So it's a 4-part fracture, therefore the risk of AVN is high. But we know that the reality can be slightly different, right? I mean, there are patients that I've seen who are 20-year-olds who have fracture dislocations from trauma and have literally sheared off their head. And when I managed to achieve stable fixation of them, the head doesn't go into AVN. Now, I just want to have that one question for, maybe all of you can have a couple of minutes on it to say, what is your position on the risk of AVN, and when do you decide that is too unacceptable that you want to do an arthroplasty?
I'll go ahead,
Okay,
Eduardo.
Michael.
All right. Yeah, I'll take it first. So I have probably a position that's a little bit on pretty far on one side of the spectrum. So I concur with your observations. We know that, and there was a question in the chat too. I think a very stable fracture essentially eliminates the risk of AVN. We know that when AVN occurs in without a malunion, with a well-reduced and healed fracture, it's well tolerated. So I don't personally change my treatment approach based on the risk of AVN. There are certainly reasons for arthroplasties, et cetera, but my own take on just kind of what I've seen and read and et cetera, I don't stratify based on AVN risk.
So you would fix most fractures in your hands?
Yes.
Perfect. I think we're on the same page here. So that puts a little bias to everybody else. But Joe, what's your view on it?
Yeah, I would agree. I mean, if it's fixable and the quality of the bone is good and the rotator cuff is good and the articular cartilage was healthy, and I'm going to get a solid fixation that's immediately stable, and I can start range of motion relatively quickly, I'm gonna fix that. I think that the rate of AVN, even if, and I think when I was training, it was oversold to us as very high. I don't think it's quite as high as it was sold to us. But even when they do develop AVN, if they have stable fixation, and they may not be very symptomatic as it's not a true weight-bearing joint. And then if they do become symptomatic, they can have more anatomic options like anatomic arthroplasty or other options. So I do think that, when necessary to fix, and I think that's still yet to be totally defined at times, when necessary to fix, if it's fixable, then yes, by all means, we should fix it.
Perfect. Eduardo, your position is from your talk is the same as well. Stable fixation is a way forward, even for difficult fractures when we can achieve it. And if you do that, we all think that the risk of AVN with stable fixation is actually pretty low. And if it does happen, then the secondary outcomes for arthroplasty and other options remain there, and they're much easier options. So a second operation isn't a bad thing if AVN does happen in some small number of cases.
Well, yeah, I agree with all of you. I think that if we can save the humeral head, but I will tell you, I will go into some hospitals because I work in several different hospitals, And for instance, I will be limited to using a striker plate or a Synthes plate or a standard locking plate of whichever variety. I have opted not to fix a fracture and go into a reverse because the fixation is not stable enough with a locking plate. So I just know it's not going to work. But if I had the option for screw fixation, I might be more courageous and fix it. So, you know, it's just my hand is being forced by the limitations of the system. And I'm talking about the medical system, which you know, forces you to use implant designs that have more limited options.
Luckily, in the NHS, we don't have that problem. We can use what we want. Perfect. Mike, you're next. Thank you.
Great. Thank you. So we're going to talk in the next few minutes about surgical approaches and reduction techniques. So I'm going to start by showing a case that we will come back to at the end. And I think this has some very relevant points based on the previous talk and everything we've just been talking about. So here's a 67-year-old female who tripped on her cat, landed on her outstretched arm, and this is her fracture. And we'll get back to this at the end, but something to keep in mind. So surgical approaches, the delta pectoral is clearly the traditional approach to the shoulder. We can get to a lot of places. We're all trained in the delta pectoral approach. But if you've treated a proximal humerus fracture, particularly with a locking plate through a delta pectoral approach, inevitably there are some parts of the procedure that you have probably found pretty difficult. I know I certainly have. And then we're going to focus a little bit just here on the deltoid splitter anterolateral acromial approach, which is essentially what I've gone to using for every single fracture pattern. Some of the specific disadvantages to the delta pectoral approach that I found, it's an anterior approach, and the fracture pathology is lateral and the plating is lateral. It often requires internal rotation of the humerus through tenuous K-wire provisional fixation. And I've seen some surgeons even release kind of the entire anterior head of the deltoid, which we know has some functional consequences. This is a dye injection study from a while ago, just reminding us that at least one of the important blood supplies to the humeral head comes off the ascending anterohumeral circumflex artery in the ascending branch, which runs right up the bicipital groove. And this is in our surgical dissection plane. It can cause iatrogenic risk to the vascularity. Additionally, we often focus on the AP view, and we know the greater tuberosity retracts proximally very oftenly. But when we look at a axillary view, you know, we're reminded the greater tuberosity can often be pretty substantially displaced posteriorly. So when we've got a large muscle mass and we're trying to come in from the front and access this fragment, especially in a subacute situation, this can be hard to access and mobilize anteriorly enough to where it belongs. So the anterolateral acromial approach, many ways to set it up. I do it this way. I have a diving board, radiolucent end of the table. I pull the patient all the way over and support the elbow on a padded plexiglass. And then we get an AP and a lateral, axillary lateral, as you see here, without moving the patient. So we don't need to extend or rotate to get our same view. Actually, just recently, and it took me too long, I'm embarrassed to say, but my shoulder colleagues reminded me of this kind of arm holder, which is invaluable, makes a huge difference. So if you have one of these in your hospital, it makes this procedure a lot easier. And then here you see, similarly, you abduct a little bit just to let the C-arm come under to get the axillary view, as you see here. So this is a really helpful thing. So the approach itself, just posterior to the anterolateral corner of the acromion. The axillary nerve predictably crosses at 65 millimeters from the edge of the acromion. So I'd measure it, I'd mark it on the skin. So as I'm getting in the deeper layers, I know approximately, or I know where to expect to find it. And then it extends 10 or 12 centimeters total in length. So we incise, then even in bigger patients or with a lot of swelling, the deltoid fascia is actually relatively superficial and it's thin. Once we get down to fascia, we look for the interval between the middle heads of the deltoid. Sometimes we see it very clearly like a raphe, this whitish stripe. Other times it's more of a palpation thing. And this is just a picture from a cadaver we had. And you can just see in this picture the topography. If you rub your finger side to side, you can feel the interval pretty well. And then we split proximally, well proximal to the nerve. And then as we get through the deltoid, we find the bursa. And it's critical to find the bursa and incise the bursa. I even usually excise a little oval to make sure I get deep enough, because we're going to need to be deep to the nerve with our plate, and we need to identify it to kind of protect it through the remainder of the procedure. We find the nerve, we put a vessel loop around it, 65 millimeters. And here's just another picture from a cadaver, just seeing kind of what it looks like, completely skeletonized. You certainly don't need to dissect it out to this extent in a surgical situation, but just to kind of see. So there are no branches in this interval, which is why it's a nice interval to split. Once we find the nerve, then we can deepen further into the bursa proximally, and we can address the fracture itself. So this is a valgus 4-part fracture. You see the articular surface of the humeral head facing out of the wound at us, and the edges of the lesser and the greater tuberosities. Different patient, but same fracture pattern. We'll get to reduction in a little bit, but as it relates to the surgical approach, generally use an elevator, lift up the head so it faces back at the glenoid. And then we've got a defect where that humeral head was and has splayed out the tuberosities. And with sutures in the anterior and posterior rotator cuff attachments, we can simply bring this back together. And I usually just tie these as a first step in the reduction sequence. And we can still get elevators in these fracture lines to fine tune the position of the humeral head in that layer. And then once the reduction is done, we slide the plate deep to the axillary nerve. There's very little tension on the nerve, and we can put screws proximal and then distal into the humeral shaft. So moving on to reduction techniques. So I put this slide up first. This is really, so there are a lot of different reduction techniques. These are just a few that have really become workhorses in various patterns that I thought I'd show. So a broad-based elevator from a lateral approach into the cancellous surface of the fracture line is really a mainstay in almost all patterns. This is a varus pattern, not particularly displaced, but by getting into the cancellous bone of the humeral head, we start by simply lifting it up, and we're trying to dock the calcar so we get good bone apposition. Clearly, the calcar can be segmental, fractured, and there's not inherent mechanical stability, but we can at least start to realign this arc and this Shenton line of the shoulder. And we're really looking at this, and we can fine tune kind of this as we need with our elevator, et cetera. Another very common reduction maneuver, which I'll use in most situations, is kind of an indirect cortical screw as a reduction tool. And so I will generally try to, and this is a pretty simple fracture, but shows the concept. I'll generally try to over medialize the shaft and get the head into a little more valgus. And then when we get the plate lined up, we can put our screw in, and we can just slowly dial this in, and we can lateralize the shaft as much as we need to realign the calcar and restore the varus valgus relationship. Another just interesting kind of feature phenomenon when using a plate as a template for an indirect reduction. There's an interesting study came out of Cleveland using a large collection of human bones from a museum, and they took kind of typical proximal humerus plates and they put them on human bones, and they found that many times the plate sits off the bone. And the implications for this when using the plate as a template is that if you pull the diaphysis, the shaft, all the way to the plate, you will over-lateralize the shaft. And this probably matters, and I'll show you why right here. So this was a patient, she was about 6 weeks out. We start by using an elevator, realign the calcar, get the plate positioned. Plate's a little high right here, but we think we're in pretty good shape. We start to put a cortical screw in just to get the plate set, and you see what's happened here is we've over-lateralized. We've uncoupled the calcar. So now we're in a mechanically disadvantageous situation. And so the way we generally salvage this is by putting a distal screw, putting some locking screws, leaving things loose, and just remedializing the shaft, in this case with a lamina spreader, pushing it over where we like it. And then just the way this patient's anatomy was, it's probably in a little bit of valgus. but and the bursa will be hypertrophic, which keeps the proximal plate off bone. But we end up locking the fracture in with the plate a little off the bone, kind of prioritizing the fracture reduction as opposed to being snug against the plate. So here's a patient. This was a 22-year-old patient who had her arm out the window of a car and rolled over. So it's kind of high energy fracture, but it's essentially a 4-part valgus fracture. So again, there are a lot of different sequences you do. As has been mentioned, these fractures are particularly difficult, I would say. And so it's important, I think you find a sequence that works for you and makes sense for you and kind of get used to doing it that way, because it makes things easier if you've got a little bit of a system that you get used to. So this is just my kind of sequence typically. So I use a lot of sutures in the rotator cuff to control the greater tuberosity fragment early. So you don't see those here, obviously. And then I use an elevator in the head, and I try to realign the tuberosity to the head. And you see right at the apex, we're still a little bit off, but this is usually a pretty good start. And then we center the plate where we like it, and we wire the tuberosity to the head, and we wire the plate to the reconstructed proximal fragment. We need to check axillary views along the way here to check the sagittal plane reduction, as well as the plate position. But once that is all set, then we've got the dominoes set up. We put in this, we know is going to be too long cortical reduction screw, and then we can pull the shaft over, and this is kind of the final piece, and then we can add our final fixation and end up with a reasonable result here. So this is the valgus type pattern, as been mentioned, easier to reduce, easier to maintain, reduce, easier to get a good outcome. More difficult and more rare is the varus or shear type fracture pattern. And you see here the calcar free fragment, which is indicative of this kind of medial compression shear kind of mechanism. So it's very important we get good alignment here. And these are ones that I'll often augment with a medial kind of fibular strut to substitute for that incompetent medial column. But again, we use our elevator to dial out the varus. So I'm just covering up my, and then, so K-wires can be used as joysticks. We use cuff sutures, as I mentioned before. Even if there's no tuberosity fragment, the cuff sutures can be used to get the head out of varus. Elevator, as I mentioned, then often leaving the plate a little off bone and abducting the arm can help reconstruct or reduce the neck shaft angle. And then, as you see here, these the aspects, and then we pull the shaft over where we think we like it. We add low screws, and we've got a reasonable reduction and a reasonable chance at success here. This is just an interesting case. I added in a little bit of a sidebar, but this patient was about 8 weeks out and came in to see us. So we started with an elevator, tried to just kind of pull the head onto the shaft again, and then took everything out. And this was amazing. We ranged this under fluoro, and it was amazingly inherently stable. So this is a good reminder to all of us here in the operating room, just how important it is for overall construct stability to get a good reduction. It really minimizes implant stresses, particularly at the bone screw interface at the tip of the locking screws, and this goes on to heal without consequence. And then finally, sometimes again we use fibular struts, and we can think about, so we often use these to augment the fixation, particularly the medial column, but these are good opportunities to use cortical screws to push and pull the shaft, to basically really focus on realigning that calcar and getting us into a nice inherent stable implant position, and then we can lock things into place, as you see here. So just to get back to our initial case, this 67-year-old female tripped on a cat. So this is a 4-part fracture, this kind of posterior medial, but not really valgus impacted and no inherent stability. So we start using an elevator, lifting up overly valgus right here, docking the medial calcar. And then this is, I think, a good indication to use a fibular strut allograft. So we've cut a short piece of fibula. We put a K-wire in as an anchor, like an axilla for a tamp. And we're really trying to tamp this up into the inframedial head, right inserted here, kind of through the lateral approach. You see, we've shortened it from here to there so that it can tip enough to get into the medial head where we want it. And then once we're here, we get a nice locking screw fixation. We've added some cement augmentation. And I've found, and the literature would reflect, when you get this fibula positioned well, you get very little micromotion, a rock solid construct, and there's really hardly any reports of AVN following a fracture like this that's enhanced with a medial fibula. And that's all I have. Thank you very much.
Michael, that was a great lecture, and some lovely slides on reduction, which I think our residents would love. I wish I had something like this 20 years ago when I was learning how to fix the shoulders. I learned the hard way, like I'm sure you did as well. Quick question, what's your indications on using fibula strut graft? When you decide that you're going to use it?
Yeah, that's a good question. Yeah, so I have several. Non-union is a good one, and a few kind of more random ones. The one that gets invoked in like 85% of the time I use it is, you know, a little bit what's been termed the terrible triad of the shoulder, as in terms of predictors of risk of failure. And that would be osteoporosis, varus fracture pattern, and calcar comminution. So when you get those three, and it's still a patient that you think would benefit from fixation as opposed to an arthroplasty, those are ones I think really benefit from some augmentation, usually a fibular strut.
Fantastic. And is it true that most trauma surgeons like yourself prefer deltoid split, whereas most shoulder surgeons go deltopectoral? I mean, I'm a deltopectoral guy.
Yeah, I think that's probably pretty accurate. You know, I've been kind of informally keeping my pulse on how common it is. I think it's becoming more common in trauma surgeons. I know plenty of shoulder surgeons that use it more for fracture fixation as well. But yeah, but it's a good question. Not sure.
A quick question unrelated to this is about what you do with the biceps. Is one from the audience. Do you guys tenotomize biceps, leave it alone, fix it? I mean, my view is I need to know where the biceps is, because I tend to position my plates slightly lateral to it, etc. But yeah, I don't want to touch it.
Yeah, from a deltoid split approach, you don't see it. You need to get across it for sutures in the lesser tuberosity fragment if you need those. But other than that, you know, I don't see it. I don't tenotomize it. And it probably just as not as a shoulder surgeon, I'm a little less sensitized to the biceps as a pain generator. So I don't do much with it personally.
Joe, do you do anything with the biceps in these fractures?
Yeah, I do the opposite. So I do delta pec. I almost always tenodese or tenotomize it. I actually will open the interval and put my finger in the joint to be able to get a sense of just if there's any disruption of the glenoid that I'm not picking up on an X-ray or advanced imaging. So I do the opposite. So it probably shows you doesn't matter.
Yeah, sure. I do the deltopectoral. I know where the biceps is, but I don't tend to open it up or split it. So yeah, it's 3 different ways of doing it. Eduardo, what about yourself? What do you do with the biceps?
I remember the biceps, the blood supply of the ascending artery, it's really just lateral to the biceps. If you suture the biceps, you may disrupt that blood supply. So, I mean, it is part of the thing, the philosophy of trying to preserve the biology. And of course, you probably can get away with suturing a few of those. But I mean, if you respect the soft tissue, the blood supply, the periosteum, you probably will get better outcomes eventually. You better blood supply, better reconstitution. And so I tend to leave it alone. Unless, of course, if I'm going to do a replacement, I'll just tenotomize it and you know, no problem. But if I'm preserving and if I'm fixing, I try to leave it alone.
Eduardo, there's a question for you directly as well to say, do you use your classification or the near classification from X-rays or CT scan? I presume the near classification is X-ray, but the real question is, are all of you getting CT scans for these fractures? We certainly do in our department. So anybody has a proximal humerus fracture pretty much will have a CT scan because we work in a major trauma center. What's your experience in your units?
Yeah, I think that we use X-rays, but most of the time to get a perfect understanding of the fracture, CT scan with three-dimensional reconstruction, they're fantastic. It prepares you for the fight in the operating room. You really know what to expect, and it helps you with the classification. So I think it's best to have a CT.
Perfect. And Joe, do you get CTs as well for your fractures?
So if it's a complex fracture pattern, I will. If it's a pretty straightforward fracture pattern, then I won't.
Perfect. And what do the trauma surgeons do, Mike?
Yeah, I'm the same way. I mean, I think, you know, the patterns are often very predictable, and with a good axillary view, you can see everything you need to see. If it's complex or if it's a dislocation or something, you know, often I actually mainly get a CT in elderly patients to look at the thickness of the head to try to figure out if they'd be best with an arthroplasty, but I don't get them routinely.
Fantastic. Well, thank you for that, Joe. I think I would like to invite you to have do your talk. So Professor Joe Aboud is a shoulder and elbow surgeon based at the Rothman Institute in Philadelphia, and also based a part of the Jefferson Institute. I think you will be talking about the rationale for when you do arthroplasty and when is ORIF suitable. So Joe, you have the floor.
Thank you, Ali, and thank you, Ramon. It's great to be part of this wonderful panel for OrthoHub with Eduardo and Mike Gardner as well. All right, my disclosures are in the Academy Handbook. So, you know, why are these fractures difficult? And I think Eduardo and Mike have already talked about this. Lots of deforming forces, osteopenia, vascularity issues. It's hard to fix tuberosities, regardless of what approach you're using. Maybe a little easier using Mike's approach. Healing is always a concern. And then, you know, what are your options down the road if at first you don't succeed? And, you know, I was asked to comment on this trial by my colleagues here. And I think they're just trying to set me up to sort of get smashed by the audience, because a lot of the audience here are probably fans of this trial, but I personally am not. And actually wrote a letter to the publisher at the time, voicing my concerns about it. And so these were the conclusions. We're going to start with the conclusion first, which is the opposite of usual, but no significant difference between surgical treatment compared to non-surgical treatment in patient-reported outcomes at 2 years, and then follow-up study in the prestigious Bone and Joint Journal from 2016, 5-year follow-up results, no difference still in the outcomes, and of course, the cost, which I'm sure your NHS system is very interested in, is you know, not advantageous with operative fixation. So there you have it. Everything we've talked about so far doesn't matter, correct? Wrong. So, you know, you can make a study show any results you want, depending on how you design the study and what sort of data you analyze. So inclusion criteria involve the surgical neck. This seems like a very sort of nondescript way to describe a indication for surgery. Displacement sufficient for a treating surgeon to consider surgery. Well, that seems like a whim. And did not have to meet the NEAR criteria. Exclusion criteria, dislocations. Well, that seems like ones that you would want to include, obviously. Open fractures, okay, that seems fair enough to include that. Clear indications for surgery, such as pathologic fractures, insufficient mental capacity, etc. Okay, now if you look at the breakdown of this trial, 1,000 of the 1,250 patients that were looked at were excluded, and 313 of these patients refused participation. So conclusion, 21% of these patients ended up being randomized into this study as far as surgery versus no surgery. So and their primary outcome measure was Oxford Shoulder Score, difference of 5 points, and then they did the subgroup analysis based on things they thought that were important. Age over or under 65, which it's pretty reasonable. But then tuberosity involvement, stratifying near 1 and 2 versus 3 and 4, that doesn't make too much sense to me personally. And then looking at the numbers in each group, I think that most of us are operating on 3 and 4 part fractures, and the number of 4 part fractures here seems to be highly underrepresented, and really the number of 1 part fractures seems to be fairly high. So again, and then 2 parts as well is very high. Surgeries, you had basically less than 2 surgeries per surgeon included in the trial. So that's concerning as well, as far as the techniques utilized here, proficiency of the surgeons, and then no radiologic assessment, which is common in a lot of retrospective studies, but not necessarily randomized control studies. So not really, convincing me that this is a well done study, and surprises me that JAMA would accept something like this. So clearly, this suffers from selection bias. So you can generalize that only patients willing to be randomized to operative or non-operative treatment can you actually extrapolate the results of this study into your clinical practice. So, patients generally aren't willing to be randomized to treatment. They're relying on your advice for things as a provider. So to me, this is a very difficult study to utilize in your practice, but I'm sure as many of the insurance companies and national healthcare systems they'll reference this as one of the reasons as to why they may deny or consider surgery as unnecessary, etc. So suffice it to say, I'm not a big fan of this study. And so again, when you're looking at these studies and trying to decide what to do, operative versus non-operative, I think we would all agree it's a multifaceted decision: a fracture pattern, bone quality, limitations of your implants, as Eduardo eloquently demonstrated, potential concern for head viability, and patient age, comorbidities, what they can tolerate, whether they're even a surgical candidate at all, and then putting it all together. And experience matters. Sorry. Oops. So, I look at this, I try to stratify first: younger, healthy, active, higher pain tolerance, and have good coping mechanisms versus frail, sick, low pain tolerance, low demand elderly patients. And they're going to go into sort of my consideration for operative versus non-operative management. Again, I think somebody with high level of activity who is going to, let's say, dominant arm with good health is going to appreciate anatomic alignment and a greater range of potential motion for their arm. So lower threshold to operate in that setting. Patient that's lower demand, higher risk patient. I think that you want to be cautious about consideration in those situations of surgical intervention, be it fixation and or arthroplasty. And when we talk about fixation, we've talked about locking plates. We've miraculously avoided intramedullary nails, but I think they're part of the discussion. And arthroplasty, which I'll try to focus a good portion of the rest of my talk on at this point. And so, Mike and Eduardo have, again, described the many failure potentials of locking plates and inadequate reductions and poor bone quality, and ending up with situations like this. And so, but you also have patients, obviously, as I was talking about earlier, who come in low demand, medical comorbidities, who have ugly looking fractures, but they miraculously oftentimes will surprise you in how they can do. And this is after it's healed. And this is the function. So this is very adequate for ADLs for this lady. She's able to get to the shelf, to get to her hair, and take care of her hygiene. So for this is a home run. And, when we look at ORIF, we talk about the good, and we have multiple studies that support the use of plates with good outcomes. And it's been around now 10, 15 years, preventing collapse of the fracture, oftentimes showing data that's clearly better than hemi and maybe at times better than reverse arthroplasty can give you. However, these studies start to show higher reoperation rates with complications, whether it be hardware related or screw cutout, et cetera, with these situations. So we look at these studies, and you start seeing now the sort of the bad. And this study here, looking by Gerber on 121 patients, screw cutout 57% of the patients with associated glenoid and potential need for revision, and they are salvageable, but oftentimes these secondary operations are not as good as a primary first decision being the right one. And again, you have this, the ugly, and you really want to avoid this. And this is where clinical decision making, and if you have a situation in the OR where you're going to potentially vacillate between, am I going to be able to do an RIF versus an arthroplasty? You need to have that discussion with the patient preoperatively, make shared decision-making decisions, and make sure that they understand what they may or may not wake up with. You don't want to have this in the immediate postoperative period and really just waste their time, increase their risk, and increase your stomach acid. And how do we know? Well, I think we know based on a lot of the things we've already talked about. But again, whether you go the non-op route or you consider hemiarthroplasty or reverse is something that I think involves a lot of training and thinking about and understanding what is going on in the field. And obviously in the last 10 years, we've moved more and more towards the reverse shoulder arthroplasty when operative indications are necessary for elderly, low demand patients versus hemiarthroplasty. And still, I still do a fair number of ORIFs for patients who are appropriate candidates. So let's look at the evidence of what it says. When I was training and finishing up training, and even up until about probably 2010 or so, we were doing ORIF or hemiarthroplasty or as primary treatments. And I mean, hemiarthroplasty was sort of a crapshoot. You could do a great operation and they may have a decent result, or you may do a great operation and they have a crappy result. And occasionally you'd hit a home run, but they're few and far between. And so the problem with hemiarthroplasties is oftentimes you'd strike out, not just only because of the technical challenges of the operation, which is not done that frequently anymore, but also because of the variable healing of the tuberosities, which obviously dictate the function of the cuff relative to the deltoid. It's not a new concept. Grammont published on it into the 1989 and 93. Never published it, obviously, but was written about. Cazenove showed this as well. The European counterparts are always ahead of us. Cerveau in France, and then Klein. Various studies showing predictable outcomes, pretty good range of motion with forward elevation, abduction of these patients. And then in the US, there's been a gradual now shift towards this for fractures that are not considered amenable to either non-operative management or internal fixation. And so the benefit of the RSA is, as we all know, is it's less reliant on the rotator cuff, and that's how it came about to be needed. Therefore, potentially fixing the tuberosities is still important and leads to better function. But if they don't heal, it's not as sort of catastrophic as it is with a hemiarthroplasty. And this has been shown in several studies now, going back to Mason's study in JBJS in 2007, looking at this in 3- and 4-part fractures. They had slightly improved external rotation in patients with tuberosity fixation. And then Journal of Orthopedic Trauma, looking at this study of just 20 patients, but still, again, reasonably good results, but not insignificant complications. Dislocations start to creep in here. Neurovascular injury is not common, but possible. Infections, acromial stress fractures, etc. And out of our group, Grant Garagos and Luke Austin, again, they echoed similar results showing that RSA for acute fractures in the elderly outperformed hemi, but you have to be balanced with your approach here and concerned about not only just complication profile, but also potentially the increased cost of this intervention. And this study by Derek Cuff, looking at a fairly large cohort of consecutive patients, 53 treated with hemi versus reverse, showing better results, lower complication rates for the reverse versus the hemi arthroplasty in this cohort, published in JBJS in 2013. So, I think there's obviously guarded enthusiasm for utilization of arthroplasty, specifically the reverse arthroplasty, but these things are not insignificant complications that can happen. Obviously, we can incur complications with any operation. Some of these are unique to reverse arthroplasty, such as acromial stress fractures, scapular notching. Neurologic complications obviously can happen with any of these operations, but you have to know what you're doing. So, my approach for this is elderly patients who, have still fairly good activity level and independence, who are not going to be happy with at times waist level or chest level activity, or potentially patients who have some underlying cuff disease and or DJD prior to this happening, consideration of reverse shoulder arthroplasty. And typically we'll utilize the deltopectoral approach here. I think that's a better approach for me, especially if I have any problems intraoperatively, like humeral shaft fracture, or have to go back in the future for revision operation. This is more of a utilitarian approach. I think that as you start this operation, identify your landmarks, as we talked about with the lesser and greater tuberosity bicipital groove, and isolate the humeral head, and oftentimes it's floating as anatomic fracture. Remove that, and then you want to, as Pascal Below has talked about in the past, properly tag your tuberosities at the tendon tuberosity interface to really have good control of them as you go for your glenoid exposure. And you want to have control of your tuberosities, my experience, prior to working on your glenoid side or putting any base plates or glenospheres in, because then you've obviously lost a lot of space, and now you're fighting yourself to get the exposure that you need. So it's pretty easy to get this all set up prior to going to the glenoid side. And then from there, it's, stepwise fashion, do the glenoid side. Oftentimes we'll put in my glenosphere, and then start to build the jigsaw puzzle back up, and using oftentimes a cemented stem, black and tan technique, as John Levy has described, for cement and auto/allograft bone, and then fixation of the tuberosities around your stem, and then cerclaging the humeral shaft to your tuberosities and stem as well to gain vertical and horizontal stability. Typically, I'm putting these in 30 degrees of retroversion for stability. And this is video from one of my partners, Luke Austin. And there's the destroyed biceps tendon at that point. Here's tagging sutures of the greater and lesser tuberosity to get control of those. And here's a free-floating anatomic head slam dunked in the axilla and just hanging out. This is an elderly patient with poor quality bone, high likelihood of failure in this situation. And you can see here, we have excellent exposure for our glenoid. This is probably the best exposure you'll ever have for glenoid insertion in a patient in these fracture situations. And depending on the system you use, prepare your glenoid and put in your peripheral screws, etc. And you want to be careful with these patients on the glenoid side as well, because oftentimes they are osteoporotic, and you want to make sure that you don't get too aggressive with your reaming, as sometimes you can over ream or even sometimes catch an edge and fracture your glenoid. Once you have your glenosphere in, you have your tuberosities tagged, and you're working on your humerus. And most of these cases, personally, I'm doing them in mostly elderly patients, and they're osteoporotic. I don't want to go line to line fit. I'm doing a cementing technique and then passing sutures through the shaft, and then proceeding with my cementing, and then putting some allograft and/or autograft bone. Previously confirmed my version there, and then impacting the stem into place. You don't want to under reduce, but you don't want to also over reduce your tuberosities, and then you want to fix the tuberosities to the stem as well as to each other in the fashion that I showed previously. And oftentimes these patients really do great in their recovery pattern. I think that they recover a little bit differently than a cuff tear arthropathy, reverse shoulder arthroplasty, but not much differently in my experience recently. The thing you have to be careful about is you make sure you restore length, and sometimes you may need to get actually the contralateral side to see what the length was there. And again, we know that the top of the humeral head to the top of the pec major insertion is 5.6 centimeters, and you can extrapolate from that to assess where you are relative to the top of the reverse humeral component to have a secondary check for recreation of length of your humerus. We do know that over lengthening, especially by around an inch, can start to become a risk factor, as Walsh has shown us, for neurologic complications, brachial plexus injuries. So I have to be careful about that. As far as pearls, tuberosity healing is a major determinant of results, whether you're doing an ORIF or an arthroplasty. And I think that it helps with arthroplasty to get the tuberosities to heal for stability and better function. In older patients, I'm going to lean more towards arthroplasty, especially if they have highly comminuted osteoporotic bone, but I will have multiple options available, and we'll talk to the patient about this. And sometimes it is a game time decision. And whatever you do, you want to think about revisability of what you choose and what the patient may have to go through if things don't work out the first time. So again, in summary, RSA for certain proximal humerus fractures in the elderly. I think they do get oftentimes more predictable function than a hemi, and in some situations an ORIF. You have to think about the longevity of what you do in these patients and the cost effectiveness, and I think we need to still study this further. And this should be limited to surgeons who have a lot of experience treating proximal humerus fractures with various modalities such as ORIF and or arthroplasty. And I think that making the right choice the first time saves you and your patient a lot of frustration, as the anchor man would tell us. Thank you.
Thanks, Joe. That was a wonderful talk. Maybe I'll ask with a couple of questions from you directly now. First is hemiarthroplasty. Are we done with hemiarthroplasties? Is it fixed or reverse? Or do you think there are still roles out there for hemiarthroplasty in fractures?
I mean, I think that if you're taking care of high energy trauma in younger patients who really have dusted articular surfaces, I think there's still a role for hemiarthroplasties. And as my senior partner, Jerry Williams, will say, that a well done hemiarthroplasty knocks the snot out of any reverse shoulder arthroplasty that he does for fracture. Now, not everyone is Jerry Williams. So I think you have to be careful, how you extrapolate that to your practice. I think that, again, one of the problems we see is trainees are not seeing hemiarthroplasties done much anymore for fracture. And to take that on in practice in your first 5-10 years, it's a dying art. So I think, yes, I think in a highly comminuted high energy trauma center like Mike Gardner does at Stanford, I think that there's still a role for that. I think in my low energy trauma population, not as much anymore. And so I don't do it anywhere near as much as I did about 10, 15 years ago.
Mike and Eduardo, do you do hemiarthroplasties often in your practice, or is it gone out of fashion?
Not me. But that doesn't mean there's no indication. It's not a surgery I do.
Yeah, gotcha. Now,
Ali,
one other question I want to ask you, Joe, is...
Ali, let me interrupt you, Ali, because
yes,
I think that what happened with hemiarthroplasties, and I would agree with Joe, the problem with the hemi really begins with the fact that it's you have an intermedullary fixation, and it's very difficult to get your height, and it's very easy to make it either too high or too low, and then you got this big chink of metal in there, so the tuberosities don't heal. Now, it doesn't mean that in the future we will not have a hemiarthroplasty option that allows for tuberosity healing and that allows you for reconstruction of the joint, which may be what we need for the younger, more active patients in whom a reverse would be a bad option. So I would say don't get rid of the concept of hemiarthroplasty, but I don't use it the way it exists at this time. But you know, I think we keep looking, we keep thinking outside the box.
Perfect. And just a question to the panel, those of you that do reverses, is how often are you making the decision on the table when you opened up the fracture and said, I can't fix this? Or is it a relatively pre-operative decision to use a reverse? Is there a situation where you go in where you say, I'm hoping to fix this, but then you find that you can't fix it? Or is it invariably a pre-operative decision that you are going to do a reverse? What's your experience, guys?
So for me, I would say it's about 10% of the time that I change my mind intraoperatively. But I have that option there because there's nothing as valuable as actually being able to palpate the bone and getting a sense of kind of the entire envelope of the patient. And so I think that's always important to have available. I'd hate for them to wake up with a procedure that I didn't talk to them about.
And Eduardo, yourself?
The same. You know, there are minority of cases where you have to have both of the options available. You don't want to be unprepared, and you do want to tell the patient that they may need one or the other. So plan A and plan B, and you have them available. And that, of course, is for those fractures that are, you know they're going to be a challenge.
Fantastic. And I think the next question I want to ask is about head splits, right? So there's always this thing about head splits where residents are worried about head splits means that you should replace it and so on. But do you see head splits as different kinds of fractures? Are there different kinds of head splits? Are there ones that you would fix? Are there ones that you would definitely say we can't fix this?
Yeah, I mean, I think so. First thing is that head splits are no longer a knee-jerk arthroplasty situation. Certainly in younger patients, we can reduce and fix head split type patterns, and they can do quite well. The other thing is, as we've gotten more experience with CT scans and stuff, we'll see. I think it's Eduardo, and I fully agree, was like the lesser tuberosity fragment is more than that, right? It's the bicipital groove, it's part of the greater, and it's part of the articular surface too. Sometimes it's a large part of the articular surface. So I think that erroneously kind of gets called a head split because it is an intra-articular kind of fracture, but it certainly doesn't behave like that. So that's just another little caveat. So yeah, I think many head splitting type patterns are fixable.
And certainly that's my experience as well in the younger high energy trauma. We fix most of them and they tend to do well. Joe and Eduardo, your experience on this, any comments on that?
No, I think Michael hit it right on the nail. You sometimes see this that look like, you see the double outline of the head, but you look at your CT scan and it's not as bad. And then the other thing is that when you open up, on the head splits especially, I tend to look at the cancellous bone to see if there's bleeding. And for younger patients, if there's any bleeding of that head component, I go ahead and fix it.
Perfect. And Joe, your experience on those?
Yeah, I mean, it's funny. When I was a fellow, it was one of the relative indications for hemiarthroplasty was, this head split injury. So it was a knee-jerk reaction. Now, no way. I mean, I try to fix the majority of them. Again, unless it's like, 4 or 5 fragments, in that situation, it's kind of foolish. But I think a lot of them do quite well. Some of them get some arthritic changes, but a lot of them are still asymptomatic even with the arthritic changes.
And that's probably one of the most important lessons from this talk today, that that was exactly what it was 15 years ago, 20 years ago. It was like head split is arthroplasty. And now all of us here are trying to achieve a stable fixation and finding out that actually most of them do pretty well. So if that's a good lesson, I think, for the people watching there. Is there anything else you would like to ask? We've taken up a lot of your time. We've answered most of the questions. Is there anything in particular that you feel like we haven't covered or have a strong feeling on these topics that you would like to share?
Not for me. Yeah, I think we covered a lot of ground. Nothing kind of outstanding major that I think has been omitted to this point.
Yeah,
Michael,
outstanding.
Fantastic.
Michael, can I ask you?
Yes.
Michael, can I ask you a question? The for the fibulas, because I don't have experience with the fibulas strut, but do you have when you revise them, how tough is it to revise, or I mean, are you, when you're putting them in, are you worried about revising them in the future?
Yep, that's a good question. That came up in the Q&A. So the deal with the fibula and then revision to a reverse is, if you pot a fibula into the intramedullary canal, it's extremely hard to drill it, to ream, and because it's just this thick cortical bone. There's actually a pretty interesting published technique. I think Andy Chu from UT Houston published in JOT. He'll open up the diaphysis of the fibula and actually cement a stem into the fibula as a workaround. But as I was saying in the Q&A, I think there's very few fracture patterns that benefit from a fibula that's sticking straight down the canal and up into the lateral head. So I really don't put in fibulas that way. I have it short and tilted. And so when it's oblique to the shaft, you can drill through that pretty easily. But certainly a long fibula that's then well healed is a pain. Yep, it's problematic.
Guys, that was fantastic. I know some of you have other commitments starting in a few minutes, so I don't want to hold you back. I would like to thank Joe, Mike, and Eduardo for joining us and giving up your precious time to give this phenomenal talk. And again, of course, Ramon and Carla, thank you for organizing this through OrthoHub. There has been a big audience attending. So without further ado, guys, have a good night and thank you again.
Great session. Thank you all.
Thank you.
Pleasure.
Thank
Bye.
you.
Thank you. Appreciate it.
Guys.